Okay, so I'm quite conscious you're 1.5 hours in and half an hour before lunch break, so I'll try and be quick and hopefully um, keep your attention. So my name is Umar. I'm a doctor and I'm the CEO of a company called Abtrace, and I've also got Harry, who's one of my colleagues, a GP, who's our Chief Product Officer. So what I'm going to tell you about is how we're automating managing chronic diseases in primary care, and really making good use of electronic health record data. So if you're not familiar with us, we are currently in 30 ICSs. We look after 3 million patients daily. We're a certified medical device. We work with 96% of the UK, potentially, and we're fully integrated, read and write, into the existing primary care systems. And what we do, or the reason we started the company is, I think all of us talk about this, about not waiting for people to be sick and not waiting for people to turn up in hospital and trying to not be reactive, so not waiting for the patient to call us and ask for a primary care appointment, because we know these people have chronic diseases and we know that they might be developing a new disease. So can we move earlier in the journey? Can we stop them from getting a disease altogether? Can we detect any new diseases they get as early as possible? Can we prevent them from deteriorating because we already know that they've got these conditions? And so we want to be moving this the other way around. Our focus should be earlier in the journey, where we can have more impact, where our treatment's going to be more effective. But the problem is that there's a lot more people at that end of the journey, because all of us potentially could have a preventative therapy, and some of us, a significant proportion, may have already one chronic disease. So you're needing to look after a lot more people than the people that walk through your door through A&E. And this is sort of topical, as it's always been, but even more so. So this was from yesterday. So we're saying that we want to focus care from the hospital to the community, and part of that is primary care. We want to be moving to prevention. That sounds good. And we want to go from analog to digital. That last bit I wasn't sure about, because we kind of are digital, right? I mean, we have electronic health records, certainly in primary care. No one's used a pen for decades. But I think that's going to be quite complicated, because if you look at primary care, so if we look at the number of appointments we use for proactive care, where rather than the patient feeling sick, we reach out to them, it's about a quarter of appointments. So a quarter of our workload is spent on primary care. But if we then look at it a bit more broadly as to what we pay GPs for, about 50% of the income a GP gets is for this proactive care. It's looking after chronic diseases. But if we look at the cost of these patients, 90% of the cost of the patients to our healthcare system are these chronic disease patients. So we could be doing even more. We could be being more proactive in GP. But the amount of workload that we're asking a GP to do, on top of everything else that they're doing, their acute appointments, and we have all of these different KPIs, and everybody knows about QOF, but we have locally commissioned services, so each ICS sets their own services. You've got CQC asking you to do certain things for certain populations. All your patients on medications are requiring monitoring. So we're asking GPs to do even more work. We're not necessarily able to give them a lot more capacity. So although this is clearly something we want to do, the solution has to be trying to be a little bit more automated in what we're doing, and to be a little bit more proactive requires a bit of automation. And the truth is, at the moment, 6 million people that we know should have a monitoring, so these are people on a high-risk drug and need a blood test, haven't had it done. And 2/3 of our visits are suboptimal. So this is a patient walks into your GP surgery, they have a needle in their arm, you take out some blood and you forget to do all the other bloods. Or maybe the person doing the blood test isn't able to make all those decisions. So we let the patient go home, and then a few months later we bring them back and we ask them to do more blood tests. And if you could make this perfect, if every appointment counted, if everyone got all the tests that we know they should have, we would be saving 30 million GP appointments a year. So that's the size of the prize. And that obviously would be good for our patients, it would be good for the business of GPs, and it would be good for our population health outcomes. So what we've built is automated proactive care. So the data is in the electronic health record system, so it's in EMIS or in System 1. And every day we pull out this data for all of our patients. So for these 3 million patients on a daily basis, we know what blood tests they've had, we know any disease codes that they've had, we know everything that is being done for them and everything that we know about them. And then we extract that data and we clean it up, because this coding is messy, it's incorrect, it's not always the same across the different EHRs. And then we have a medical device certified clinical algorithm. So essentially we encode all of those guidelines, whether it's cough or medication safety, and we know what each patient needs. So as of today, I could tell you, at your practice of 10,000 patients, these people need these tests and these people need these others. And all of that is happening in the background every day. So we can see everything that there is to know about the patient. We can know in the sense that we can make the calculations a doctor might do, and then we can act. So our integration also includes the ability to send a patient an appointment booking link or a message automatically. So now that we know who needs what, we can reach out to them, we can offer an appointment with an appropriate member of staff, and we can make sure that that member of staff does everything. And finally, we can measure the cost of that, because how much is that GP appointment costing you is sometimes difficult to calculate, and how much is the value of that appointment is difficult to calculate, and we can measure all of that. So what I'm going to do now is I'm going to just show you what that looks like in real life. So that is EMIS. It's one of the electronic healthcare records that you use in primary care, and this is Abtrace. So what happens is you log into Abtrace in the morning, and from that moment onward, if I've got a patient open in EMIS, I can open that patient in Abtrace and I can pull out what that patient needs. So if I'm a receptionist, if I'm a nurse, an HCA, I may not know the specific guidelines, but I know my patient needs these tests. And even if they've come in for one test, I will make sure that they do all of these tests and they don't leave until all these tests are done. And I will also make sure, and essentially, although we're giving a relatively straightforward thing, beneath it is a lot of different rules. So it's a clever system that's taking into account all the different rules that apply to this patient. So that patient needs a kidney function test, but they need it for multiple reasons, because they're on multiple medications, because multiple bodies have guidelines that apply to this test. So we're not telling you all of that detail unless you want to know, although you can hover over that and tells you the detail. Ultimately, they need these tests. We should get them done. And at the end of that appointment, all of this should go green. That would be the definition of an effective appointment. And I can open that patient in EMIS. I can write this blood pressure in, and when I save it, we'll code that back into EMIS. So the first thing is making every population, every contact count, every encounter count. But then we also want to be able to quickly access. And again, I'm not sure how familiar you might be with GP records, but if you were to run a search and you wanted to know who needs a blood pressure or who is overdue for a smear, that typically takes 8 to 10 hours to run. And so you're just waiting to find out your list. Whereas with Abtrace, it takes 30 seconds. So if I wanted to know my population who needs, who's on methotrexate, I click enter and it should instantly load all the patients that I need. If I want to know who needs a smear, I put that in and it instantly gives me that list of population that needs to be brought in, and I can look at how overdue they are. Or I could look at by capacity, what are all the patients that need blood pressure? Well, that's the population. I can look at the people that are opportunistic, so these are people that they don't need a blood pressure today, but they're going to need a blood pressure, so we can look ahead as well. So you find all these patients. You might want to exclude the people that are housebound, for example, because you're not going to ask them to come into your practice. And so you can instantly find them, you can select them all, and you can send them a message. And this is something that GPs do all the time. But you can also automate that. So now that I've found out who needs what, I can choose to automatically recall them. So as of today, there's 405 people that meet this criteria, but I can essentially say from now on, every time someone needs something, I want them to be messaged and offer an appointment. I don't want to have to chase these people. And so it will tell you every Wednesday at 2 o'clock, we're going to send these messages. I don't want all 400 people to be called in, so I'm going to choose 27 patients a week, and I'm going to choose the highest priority patients first. And this will just every week, it will find the patients according to those clinical criteria, which is updated daily. It will message them, and then I can let the patient have a self-booking link. I can say, well, for this population, actually, it's the nurse appointments that are available, so I can put that in, and they're going to only be shown appointments with a nurse. And I can say, okay, that's blood pressure is what I'm going to tell the patient that they're coming in for, and then I can put in a message. And what this will do is it will send them an email, And if they don't have an email address, it will send them a message and it will write that into the EMIS record. And that will just run on a daily basis. All the right people will be found, identified, and brought in. And what the patient sees is a booking link like this. So they click. It looks like the NHS app, so it's all NHS branded. They put their date of birth in, and they are able to book themselves in all the appointments that they might need. It tells them you need a blood test. They only see the appointment slots that we've made available to you, and then they can book in. And once that's booked in, all of that will go back into your EMIS record. So that looks like that, and you know what that patient is coming for. And I won't dwell on all of the functionality, but part of this is related to coding, because if you don't code your patients correctly, and this is a problem for not just GP surgeries, but other organizations that are trying to do something for population health, you're going to miss these patients. So what we do is we look at the records and we say, where are the codes that are missing? So these patients are attending heart failure clinics, but they don't have a heart failure code. So they're not appearing in that population. And you can say, well, yep, I agree. Select the code that's appropriate, and that will code that in. And we've found 60,000 patients so far in the UK that would benefit from a code. And so you've set up an automation, you're able to identify any population, prioritize them, bring them in, get the right tests on. And what we also want you to be able to do is to be able to look at your performance on a daily basis. And whether you're an ICS or you're a GP surgery, you want to be able to know how you're performing. So what we do is we build dashboards that are real time. And so these correspond with the population. So I can see as a GP which of my staff are logging in, how many logins do we have. I can look at how I'm doing on particular monitoring. So I can say, well, how's my ACE inhibitor monitoring? DMARDs are high-risk bloods, so how am I doing on that? And you can see your performance for a single practice, or you can look at multiple practices. So what you've got is an actionable dashboard. You find out that there's a problem. My number of overdue patients for this particular group are going up, and you can go to the population dashboard. You can find that population, and you can action them right then and there. So what you do and what you're measured on are compatible. They're looking at the same thing. And so I'm just going to talk a little bit about how we make sure people use the system. So every week we'll send you an email. We'll tell you how many people came in, how many people had all the right tests done. And then we asked our practices what they would benefit from. So people use this for NHS health checks, for flu vaccines, for high-risk medications, for weight checks, BMI monitoring, urine ACR, etc. And we've turned a task that was taking hours of time for various members of staff and still been done partially, to something that takes now 60 seconds to set up, and you manage to get the vast majority of your population through the door and have all of their tests done. So there's a number of case studies that we can talk through, and we've got a stall outside. But what I want to emphasize is that this is good care for patients. It's quite satisfying for staff because you're not having to do this very mundane, repetitive stuff. Your healthcare assistant, your nurse, who were a little bit limited in what they're able to do, were now able to perform as if there was a pharmacist or doctor sitting next to them telling them what needs to be done. And the patients are getting more from each appointment. But at a system level, we're basically improving your chronic disease care, because we're identifying more people that should be getting the care. And then we're at large scale, without adding any appointments, actually taking away some appointments, we're making sure they're getting the monitoring that they need. So at an ICS level, this is what the impact is. And it's a busy slide, but I'll point you to kind of the overall impact. If you just look at cardiovascular disease, you would be able to potentially save 45 million pounds of savings for a single ICS on better management and identification of cardiovascular disease. So this is preventable strokes, preventable heart attacks, looking at up-titrating the medications appropriately when you've identified a problem. And what you get, and I won't dwell into all the evidence, but what you get is a task shifting. So you get work that was previously being done by doctors moving to HCAs and nurses. So that means you're doing fewer appointments, you're getting your spend back within 3 months, and you're also reducing the number of hours required. And in a workforce crisis, that is really meaningful. And it's something that our GPs are really happy about. And that's sort of the feedback So people find it intuitive. We don't do a lot of training. It takes 30 minutes to go live. Most staff will just log on and get on with it. And I suppose the final thing I should talk about is compliance. So this is challenging because we're accessing large amounts of data. We're making medical recommendations. So we are a certified medical device. We've done years of certifications and now been approved over and over again, so 30 ICBs so far. And so we've not had any problems with this, and this is all done and dusted. And so we're supported by various NHS bodies, Innovate UK, NIHR, NHS Innovation Accelerator, etc., and we're live across the country. So you'll be super pleased to know that I'm going to give you 20 minutes back, and we have a stall outside, so if you do want more details, and if you are in the space, please let us know. And if you know other people that are in the space, please take a leaflet and get them to get in touch with us. And I've also got my colleague Harry, who's got more leaflets if you want a leaflet right now. I think we have some questions. And we were supposed to have a chair, but we don't have a chair, so we're like doing this ourselves. So I don't know if you guys want to come up and take any questions, and then... Or are you the chair? Oh, okay.
Yes, sure, yeah. Hi.
I'm Rayne Auditorium, and as I walked in, I was late because I had some questions to answer myself. I heard you talking about our service at Airedale.
Yes, I loved your presentation.
You mentioned you wouldn't want to emphasise the increased deaths in care homes. Those are expected deaths that would have died in hospital had we not supported the staff to look after them in care homes.
I know, I understand that. Obviously, yeah, I do understand that. I think the point I was making was that people who own care homes don't want patients to die in their care home.
I disagree. I'm surprised you said that. And we actually do virtual verification of expected death now as well with them using our video system because it saves GPs and district nurses having to come out to verify death. So we do a lot with them.
Well,
Service in place.
I mean, certainly around the country, the experience is that when patients start to deteriorate in nursing home staff are very keen to get them out of the nursing home, even if they're going to die within the next day or two. And you know, you've done a good job sorting that out, but that's definitely not universal.
No, I absolutely agree with you, and that's exactly what we're there for. We're 24/7.
Yeah, so, and to come back to what I was talking about, which is virtual wards, in some areas, it is an exclusion. Nursing home, the patients in nursing homes can't be onboarded into virtual wards. And I was trying to talk, I mean, you may not have caught what I said, but I was trying to explain why that's difficult for some people. So, for example, you know, if we have a patient with a chest infection in a nursing home, and people want to try and manage their infection in a nursing home with IV antibiotics and fluids and so on, that despite the fact that there are nurses in nursing homes, that very many of them say that, you know, they're private organisations, and that they say that, I'm sorry, they're not happy for NHS staff to come and deliver that sort of care in their nursing home, and they're insisting that the patient's transferred out. That is a huge problem. And adjusting, and that's why it's good that the nursing homes are mentioned in the guidance. But I think it's still a huge issue trying to actually deliver virtual ward care in nursing homes. I think it's a huge problem.
I agree, and I also mentioned the head injury issue that we have with the NICE guidance, where we're having to bring people into hospital from care homes who bump their head just because they're on anticoagulant.
Yes.
And I think it's exactly the same issue.
Yes.
There has to be a different guidance for people who are in the twilight of their years, you know, who aren't going to benefit from coming into hospital.
Thanks. Go for it, yeah.
Can I just ask a very basic question? Why is it a 2-week cut-off for a virtual ward? And if we're in a virtual ward bumping up against a 2-week deadline, then what happens? What do you call that?
So I mean, it's not that people are told that they have to off-board a patient, but so the national team monitor length of stay in virtual wards. Okay, so there's a fortnightly data upload to a Foundry, and they look at the length of stay. I think it was obviously arbitrary that number was come up with, 2 weeks. I think it was a surprise to people who supply technology, because a lot of the tech that's used for virtual wards was actually really designed for long-term condition monitoring, like we were hearing about, and it had to sort of been rebranded as equipment that could be used for virtual wards. But people, you know, who are interested in heart failure, who are interested in COPD, were really interested in how to use tech to manage people at home for the long run. They're funded from different budgets, because one's from the UEC budget and one's from long-term conditions, and so that is, but I think the real reason that it was given was to try and stop people just relabeling all of their heart failure or COPD population as virtual ward to get the numbers up, but to have it as a focused intervention, as an alternative to the patient being in hospital. Now, I mean, I know in Cambridge you've got experience with people being in it for much longer for your haematological patients and things, and it's not an absolute cut-off, but it's just to give an idea. And I agree with the point you made as well about, often people have found that their length of stay can be too long. Let's say an average length of stay in hospital for heart failure might be 10 days, okay? And maybe you can take 3 days off that by putting the patient in the virtual ward, but you might find that actually you're putting the patient in the virtual ward for 10 days. So, you've actually, there are pros and cons of that. You're in touch with the patient for 20 days, so that's what I mean about a much softer landing in the community, but maybe you didn't really need to have the patient in the virtual ward. So what a lot of people are doing, like Andrew was saying, is you then start to shorten the length of stay in the virtual ward, but that has the unintended consequence that your occupancy drops, and then people start panicking about your occupancy, but actually you're just trying to have it as a more focused intervention. But I do think it is a good idea to put that 2-week thing in there, because I think another key reason is to stop people relabeling their OPAT service as virtual ward, which is, I think, a big challenge.
Hi, sorry, just wondering, what is the ratio of nurses to clients, and do you operate 24/7?
Yep. So at Cambridge we run 24/7, and that was a decision that was taken right from the start. We said, if we were mirroring a physical bed, then we need to be taking ownership for this for the patient 24 hours a day. We operate at 4 nurses during the day, and 1 overnight in terms of our staffing ratio, and we have 1 junior doctor and a consultant, but that's to manage up to about 70 to 80 patients.
Yeah, the national guidance is 8 till 8, 7 days a week, okay? So I think in East of England, let's say we've got 20 virtual wards, there's about 3 that do a 24/7 service, the rest don't, they just follow this 8 till 8, and when Gerved visits, they're interested in the 8 till 8 bit, so if you're doing 8 till 6, they want you to do 8 till 8, and particularly they're interested in your cover at the weekend. They're very interested to know what the escalation arrangements are out of hours, and usually people have a arrangement, with 111 and so forth. What was it? There was the second thing you were asking about that? Yeah, so I've struggled with that question myself, but I think the answer is there is no answer to that, okay? Because it's to do with acuity, and when people say it's 4:1, you can't specify that across all virtual wards. So in CLCH, who's our community partner, they have brought out something called they used an acuity tool where patients are put into 4 tiers, and basically a patient who's in tier 1 is a patient who's just being remotely monitored and spoken to on the phone, and in tiers 2 and 3, essentially patients are being visited at home about 2 or 3 times a day, or twice a day, and so you can then, if you look at your 100 patients in virtual ward, you work out what tiers your patients are in. You can then work out the number of home visits that need to be delivered on each given day, and you work out for your team how many home visits your team can do in a day. Then you can sort of work out. So that's the sort of way into that people have found helpful, I think.
What are your kind of solutions around logistical problems with delivering tech and things like that, getting them back?
What? Sorry, can you repeat the question?
Sorry, like logistical issues around delivering tech or getting tech back that you use.
So the way we do it, because we're doing a step-down model, so the patient is in hospital at the time, so we go and visit the patient at a time and onboard them, so the delivery of the tech is sort of done at point of admission. In terms of the discharge process, so it can be a bit tricky, so we're at the point of discharge, we're then talking to that patient at that point and saying, you obviously got the tech, how can we get this back? And we have a variety of different solutions. So it might be the patient brings them back in, or family or carer brings it back in, drops them off on site. It might be that we have to send a courier to go and collect. one of the big things we're working at the moment is volunteers within the hospital. So we're trying to arrange for a volunteer to work with virtual ward who will be a driver to go around and collect kit. When we scale and get bigger, the option to use the Royal Mail Health will be an option, but we're not big enough yet. There's a criteria around how many packages you're supposed to have.
I think some commercial providers offer that as part of the service, getting the kit back. We partner with the Red Cross, who help with going to collect it from patients' homes. But yeah, you don't always get everything back, that's for sure.
My question is, Rachel, by the way, I really enjoyed the talk earlier. I'm a GP partner in North London, and I also work in the care GP. And we talk a lot about remote monitoring where there's a reactive or acute situation. But obviously as GPs, we do a lot of the proactive monitoring that Abtrace mentioned. I actually have Abtrace at my surgery. And I wonder whether there's a platform or integration where Abtrace can actually be used in care homes, because a lot of patients do need routine monitoring. So I go in and do dementia reviews, learning disability reviews. A lot of these patients are on anticoag for AF, and they don't often get GP ward rounds. They might have in-house phlebotomy, they might have rapid response chat team, and these are missed opportunities where patients are being visited and seen but not having everything they need to get done. And often the GP then doesn't do the quaff for the care home patients because they can manage, to get their targets hit just by getting the patients who come to the surgery. And so it's almost giving them a lesser quality of care. So I wonder whether there is a collaboration that can be had.
That's probably, I mean, from our perspective, it's, we know which patient needs what, and we know that throughout, and that can be made visible to any party. But I guess the question is, and we are bringing in some degree of remote monitoring as well. So if you can get your blood pressure submitted and you don't need to come, and there doesn't need to be an appointment, we know who needs a blood pressure and doesn't need a blood test, and we can try and arrange that and potentially get other people to submit it, even if there's not a direct device integration. But I guess the question is sort of how much the virtual ward pathways have their hands full with the core stuff versus trying to go a little bit further and be more preventative and proactive in terms of managing that, new conditions as opposed to kind of the hospital.
I mean, I think the key interventions in nursing homes are really, really evidence-based, aren't they? Like all of that stuff about medicines reconciliation and, advanced care planning and so on, that, all the data shows that those are highly, highly cost-effective things to do. And yet, nationally, it's extremely variable picture with, some areas where all the nursing homes, every patient is all, the I's are dotted, the T's are crossed, they've all been visited and so on, and other areas where it's just like, that's definitely not the case. So I think that's the anticipatory care bit of it. I think when someone in a nursing home starts to deteriorate, access to virtual ward is really important. Now, there are some areas where virtual wards that the local GPs are heavily involved in it, but in many areas virtual wards are delivered completely separately from primary care, and many GPs don't want necessarily to be involved at the point that their patient is onboarded into the virtual ward. They want a separate medical team to take over at that point, and then the patient to be transferred back to their care when the patient's been off-boarded. So there is a sort of break in continuity there, but I think, my experience of talking to people about it is that GPs feel that with their workload the way it is, taking over medical responsibility for a patient who's been onboarded into a virtual ward, especially in a nursing home, is not something they really want to do. So there is a separate medical team involved. But if I look at our virtual ward, we started off with the medical staffing was essentially hospital consultants. It's about, we brought in a lot of GPs to work with us now, and a lot of the community frailty virtual wards where patients from nursing homes are being onboarded, the medical cover is almost entirely GPs, who, often doing a day or two a week as sort of, portfolio career type thing. And I think that, so us working really closely with GPs in our virtual ward has been really helpful in terms of how, how we think about doing this. I think GPs, hospital doctors have often actually these days very rarely met GPs. I think, all the original arrangements for us to socialise together seem to have sort of dried up. And so, it's been super helpful for people to actually spend time together. And people have forgotten, I think, in hospitals just how comfortable GPs are looking after patients in their own home, which obviously hospital doctors are much less good at. So.
Lunchtime.
That sounds like it.